can you explain exactly what perimenopause is and what menopause is?
Yes, that is a very good question. So the difference between perimenopause and menopause is really reliant on your menstrual cycle. So think of your menses as a vital sign. So whenever you go into the office, someone asks you, well, when was your last menstrual period? So using that as the guide, then we can look at, wow, so menopause. Menopause naturally occurs in the early 50s. And menopause is when you have your last menstrual period, and then there's an entire year that goes by. And then it's a point in time where women can declare, I'm menopausal. We don't use the term postmenopausal really that much. We don't really use that at all. We're menopausal. And then there's the whole section prior to menopause, which is perimenopause. And perimenopause can be a natural condition. And then there's also menopause that can be induced. So you can have younger women that they've been either surgically or medically or possibly genetically having menopause. And menopause can occur early or premature. So that's by the definition of age. So if you've stopped your menses and you're less than 40 years of age, then that would be considered premature menopause. If you've stopped your menses and it's been a year and you're younger than, or you're 45 and younger, then that's early. So that alludes to the fact that there is actually a transition that you got to that point. And so perimenopause symptoms can occur as early as in the 30s. Let's say you're somebody who is going to undergo premature menopause or early menopause, you're going to have perimenopausal symptoms earlier. So it's important to be aware of what the perimenopausal symptoms are, because early perimenopause can occur, up to about maybe 5% of us. It could happen. It's not unusual. And then premature can be about 1% or 0.1 to 1%. And then there's premature ovarian insufficiency. And that also can occur. And women can kind of have they can have perimenopausal symptoms, but at the same time, they haven't yet had their last menstrual period, but they're showing signs that there's some ovarian function that is declining. So there are some, you really have to know the symptoms, and you have to be aware of how you feel and to not be dismissed, even if you are still having menstruation, because menstruation can occur, but unless you chart it or you're thinking of it, you may not notice the subtle differences that can occur in regularity, frequency, the interval, the volume. So it's important to keep that in your mind, maybe calendar, as early as 30, mid 30s. The average age, I just want to say the average age of menopause for the population in general is 51 and a half.
But what are the symptoms of perimenopause? And then once you hit menopause, so you're in where I am, what are then those symptoms or things to look out for, just so we can have a clear understanding, so everyone is like, okay, I've heard it from a doctor. Here are the facts. What are the facts, Suzanne?
Well, I mean, the facts are that everybody's going to have their own experience. So that I think that also makes this kind of confusing to people. But what I will say to you to frame this is it's a lot like puberty. there are certain steps that are occurring, and we understand the physiology that is driving it, but everybody does not experience it exactly the same way. The kind of manifestations of it are unique. There are some through lines, and I'll share those. But I think when people, again, understand, and you've already said this, this is a physiologic event. This is not a disease. It's not like there are diagnostic criteria for the disease that you have. This is not pathology. This is normal. The problem is it's mysterious because we haven't been talking about it. Nobody talked about it to us. So I want people to understand that. Having said that, you know, the amount of time people can spend leading up to menopause, so perimenopause or the menopausal transition, can be up to a decade. For some people, it's more. So, and I think this is where it can get a little confusing too, because the other thing that I see is that people are very identified with their hormonal selves, but their hormonal self is not fixed. That will change over the course of your lifetime. Your hormonal cycle, your period, and everything that, you know, leads up to it and happens after it is not the same at 13, 20, 32, 45. So it isn't, I really want people to take this in. It is not a disease. Okay. Now that doesn't mean that if it's uncomfortable, disruptive, you don't deserve attention or help or support. I'm not saying that, but when people get into like, I need to know what these things are, it's like, that's probably not going to help you. What I do see is this: the most classic stuff is that people who do experience a menstrual bleed start to notice changes. A lot of times what we'll see is they start getting closer together and heavier, and then people start to skip. So if you have an IUD or the pill or, you know, a hysterectomy, this is not going to be you. During that time, we're seeing the ovary is functioning differently. It's making different amounts of estrogen and progesterone at those times of the cycle that they do. And I'm not going to spend a whole lot of time on that. They can read about that, or we can, you know, put some links up. But we do see that progesterone, which dominates the second half of our cycle from ovulation on, actually is declining. And it's declining in such a way that we have a little bit more estrogen, even though that's declining, than progesterone. And this is where people start to get into a lot of the really dark moods. If you've had a history of anxiety or depression, it can really come back. If you've never had panic or anxiety, it can happen. I had that. I'm Jewish. I'm an anxious person, but I was not like, I didn't have PMS. And in my late 30s, I was like dark, super irritable. Stuff that would be like annoying but manageable is like the end of the world.
Why do we all suffer so much? Why do we put ourselves in the suffer camp?
I don't know. I mean, it's very obvious to me why women choose suffering. There's something wrong about acceptance of pain. And we've been taught, and maybe it starts from early on, we didn't necessarily know we could stop pain with menstruation. We didn't take those steps, particularly our generation. I don't recall taking anything when I was young for painful cramps. And then take it the step further. There was the entire movement on natural labor, which I understand. Labor is beautiful. I love being an obstetrician. I had 5 babies myself, but in some odd way, I thought I had to do it natural because I took care of women doing it natural. And I did it naturally the first time. That was hard. 20 hours of labor. I think I had things happen that I may not have if I had had an epidural, but we're just trained to go at it so hard. We're so strong. We are so strong. And then take that even further. We are being told that natural is okay and menopause. Yeah, I mean, maybe some people can do that. For the majority of women, though, if you were sensitive with your menses or if you had PMS, you're probably going to feel some stuff and have some issues when you're transitioning. And why do we need to do this natural? We're living longer. We're asked to be as productive, if not more productive. We don't need to shy away from giving things to ourselves or helping ourselves with things that have already been in our body and we've made. We've taken things to stop pregnancy and prevent pregnancy. So we shouldn't be afraid to make things better for us so we can enjoy our life and be productive and not suffer. That is, I don't know why, but I think a lot of times there are advertisements, there's movements to tell us that we have to be natural, naturally beautiful, naturally healthy, natural. I love the whole movement on plant-based diet, eating naturally. All that part is lifestyle modifications that are good for our bodies. But naturally, yes, we naturally age, but there are tons of medical conditions that we treat ourselves for. We don't let the natural course of diabetes take over our life. We don't let the natural course of cardiac problems take our life. If we were born with a genetic condition or disease, we don't naturally let it end our life. So we are living longer. We have the opportunity to feel well and better. And year after year, we should ask ourselves, how best can I optimize my quality of life to match my longevity of life?
For everyone listening, if you're having I know there's so many symptoms and we probably won't go into all of it, but for being where we are in life and hard charging careers, and like we talked about, aging parents and the kids, and I just went through college there's so much on our list that we're doing every day. To feel like you're basically losing your shit is a scary place to be.
Mm-hmm.
So can you take us through just sort of the benefits of like our brain? Because it's still to this day, and I know the study has been debunked, but there was that study that was 20 years ago that scared everybody off hormone therapy.
Yeah.
And people are still scared. I hear the chatter and people are like, I don't want to do it.
So, in the last couple of years, a couple of small observational, ridiculous studies got blown out of proportion on social media and in the news about dementia and HRT and all that stuff. Look, 45 studies reviewed, massive. That's a massive, overall, if you start hormone therapy within 5 years of your menopause, you are much less likely to develop dementia. If you have the ApoE4 gene, okay, which is the Alzheimer gene, one of the Alzheimer related genes, and you were lucky enough to happen to have been prescribed hormone therapy as early as perimenopause, you will decrease your risk or decrease the onset. You will delay the onset of Alzheimer's and the severity of your disease with hormone therapy. It's incredibly protective of the brain, but we have a window of opportunity. Okay. And so when I'm counseling patients about cardiovascular disease and neurodementia, I'm like, okay, listen, neurodementia and cardiovascular disease are related to how long our body goes without estrogen. It's less to do with HRT. It's more to do with how much time did we go off? Okay. How much time were we away from it? And you are more likely to develop cardiovascular disease the longer your body is without estrogen. The studies were done for 10 years or up to age 60. That's why those numbers are there. It does not mean you may not have benefit after 10 years of the age of 60. It means that we can only say, because of studies, that, and that's out there. The WHI has been debunked, has been retracted, but there was a big fanfare when it was released and the world went crazy. It was the #1 medical story of 2002. #1 health story in the news was estrogen causes breast cancer and heart disease and all this stuff. So you are most likely to have cardiovascular benefit the earlier you start, the shorter the time period that you have away from your estrogens, especially if you go through menopause on the young side. Okay. Again, because when you go through the young side, that's a longer time you have to live without estrogen. The best estrogen in the world is the one you make naturally. But that's going to stop one day. And we haven't figured out how to delay that. I think we would be unstoppable. We would live a lot longer if we could figure out a way to stop menopause.
I have a question for you because as I was again digging around and getting into, I love all the technical stuff, and we could talk for 5 hours probably. But you mentioned something on one of your videos. It was called musculoskeletal syndrome of menopause.
Yes.
So I wanted to ask you about that because we all know I've had other doctors on. We've talked about sort of symptoms of menopause, but I've never heard and treatments, but I've never heard of this sort of overall like discomfort and pain related to being in menopause. Can you explain that?
I sure can. So the term, the nomenclature, musculoskeletal syndrome of menopause, you may not have heard that because I made it up and now I'm publicizing it. But here's what it is. Estrogen works on everything. We know it works on our brain, Lisa Mosconi's work. We know it works on our hearts. We know it works on every organ in our body. Why wouldn't it work on our musculoskeletal system? And lo and behold, the 6 ways estrogen walking out the door affects our musculoskeletal system in 80% of all midlife women is number 1, total body aches. This was a huge problem for me before I started on estrogen and cut out sugar. My whole body hurt. You don't know why. You haven't been hurt. Sometimes you're diagnosed with fibromyalgia and it's not that at all. It's really your perimenopausal and nobody knows what to call it. So total body aches is called arthralgia. The reason we get that is because estrogen is a huge anti-inflammatory. So without that powerful anti-inflammatory, we just become hot and red inside and it feels like pain. So arthralgia, number 1. Number 2, we lose our bone density. Estrogen is critical for the maintenance of the balance of bone building. So here's what I want people to understand. In midlife, we can still build bone, but because estrogen has walked out the door, the cell that breaks down bone, the osteoclast, the OC, osteoclast, is uninhibited. Normally, estrogen dampers it down, so the building cell, the blast, and the clast are about similar. Well, the clast gets out of control when there's no estrogen to damp it down, so we break down more bone. That's what's happening. So in between perimenopause and menopause, we will lose 2 to 3% a year, so that without even knowing it, you've lost 10 to 20% of your bone density. And many women do not lay down enough bone as young women anyway. So we're starting behind. So number 1, arthralgia. Number 2, loss of bone density. Number 3, without estrogen, we have an increased speed of muscle loss. There is a phenomenon with just simple aging called sarcopenia. We just start to lose muscle. Without estrogen, that ramps up. So that's number 3. Number 4 is our cartilage, which is the lining of our joints, is unprotected. Cartilage is a matrix, like a sponge, and estrogen protects that matrix. Men before 50 have more arthritis than women. After 50, when estrogen leaves, women have more arthritis than men because our cartilage can't hold us anymore. So talk about leading to disability and future surgery and lots of pain. And then the final category, 2 categories that I put under musculoskeletal syndrome of menopause, not only do we get inflamed and we have arthralgia, we get inflamed all over the place and people show up with things like frozen shoulder, which is a huge topic all over the place now. You did nothing. You did not bang into the dresser, but your shoulder is so painful, it won't move, and you can't hook your bra like overnight. That is the inflammation that goes along with this. And then finally, we have redistribution of our fat from our periphery to surrounding our organs, which is the belly fat everybody hates. So those 6 things are the musculoskeletal syndrome of menopause. And 80% of women will experience these problems, and 25% of us will be devastated by it. And they are one of the leading causes of frailty. And so we got to get in front of it, and we got to start as soon as we find out about it.
Let's dig in about the nutrition piece really quick, because I have not talked about it yet on the show. And, there's talk about an area where people get so much information, disinformation. It's like there's kale here, there's fasting here, there's don't eat nightshades here, there's quit alcohol. There's just so much.
Yeah.
What the hell do we do?
Okay.
What do we do to have good nutrition?
First of all, don't assume good nutrition is, you know it when you see it. So many of my patients and my students in the Galveston Diet Program are like, no, but I eat healthy. I'm like, okay, let's break down. Let's throw healthy out the window. Let's not talk about healthy. Are you eating a pro-inflammatory diet or an anti-inflammatory diet or neutral? What does that mean? Well, we have validated scoring systems for that. You can look at dietary recall and look at things we know promote inflammation, like high levels of processed meats, processed carbohydrates, not rocket science here. So, how much of your diet is filled with lean meats, with vegetables, with fruits, with legumes, with seeds, with nuts, with things that we know fight inflammation naturally. When we're looking at kind of the core components for menopausal women, and I've done a tremendous amount of reading on this and looked at it over and over again, we know that there's some key deficiencies that women have across the board in menopause. One is fiber. The average woman in the US who thinks she's eating healthy is getting about 12 grams of fiber in her diet per day, and she needs minimum 25. When they found the women who, and this was I think the SWAN study, when they found the women who were having more than 25 grams consistently in their diet per day, they had less visceral fat, lower blood pressure, and better insulin resistance, lower diabetes, therefore. So, fiber in your diet is huge. Now, that does not mean, and I'm a fiber sale, I sell fiber, so take this into full account, does not mean you need to run out and buy a fiber supplement. When you eat food that is rich in fiber, like the nuts, the seeds, the legumes, the fruits and veggies, they're packed with a lot of other stuff that's healthy too. The anthocyanins, the vitamins, the minerals, the nutrients. So you cannot just assume when we say a diet rich in X that you run out and buy that supplement. You're way better off getting it through food, because more than likely the foods that are rich in that one particular nutrient are rich in multiple other things that are going to keep you healthy long-term. So 25 or more grams of fiber per diet per day. I don't love restriction, but there's one key thing you really, really, really should put a bunker on. Not to say never, but added sugars. I'm not talking about the natural sugars found in fruits and vegetables. I am talking about sugars added in the processing of foods. So either you add it through cooking, you add it through processing, it's in alcohol, but women who limit those added sugars to 25 grams per day, that is 4 tablespoons, okay, consistently have much lower visceral fat. Visceral fat is what we use as a measure for chronic disease risk. It's really the easiest way to do that. Much less visceral fat, much lower insulin resistance, just do better. Third thing, there's a few things that we know that women are deficient in the vitamin mineral, world. One is vitamin D. 85% of my patients are deficient in vitamin D, not just low. I'm talking like bottomed out low. Multiple reasons for that. We're protecting our skin against the sun. We're not absorbing as well with age. Menopause changes our gut microbiome, all of that. So with that, most women can take, the vast majority, 4,000 international units of vitamin D a day safely without worries of toxicity.
What do we do with the doctors we have if they're not supporting us? What can you tell everybody?
I think it's complicated because, I think people who have access to care and do have choices, if their doctor is hostile, dismissive, and rude, they really should walk. They should just get another doctor. And there are plenty of sources online. Menopause.org has a physician locator. These are doctors that are trained by North American Menopause Society, which is now changing to Menopause Society. I don't think that's the only place to go, by the way, but I think that's at least, these people are well trained. I think that some of the online platforms like Evernow and Geneve and Alloy are really, I think they're doing a good job. They're not doing a deep dive. Let's be honest. They're doing a quick telehealth. Here's your hormones. Okay. So it's better than nothing. But I do think you got to be careful. If you come in and you create a hostile environment, it's not going to benefit you. So this may, some people might be like, I'm not here to take care of my doctor's feelings. Cool, agreed. But I think you have to understand what you're working with. This person has worked really hard to get where they are. They actually do care. They really do. And they probably don't have the training, the time, or the understanding. So I don't think approaching them in a way that's like attacking their knowledge base is the best way to do it. I think if someone's fighting you on something, yes, bring it. And I have helped patients with this where they're seeing me and their, oncologist or hematologist is giving them a hard time. I'm okay. Here's the article. I have a whole thing in my book on how to advocate for yourself in a cooperative manner that will bring you and your doctor into better alignment or help you understand if this is a doctor you can work with. I think a lot of it is just asking questions. Why are you saying I can't do this? What if I did that? I mean, whatever, there's a whole thing. And it was really funny. I had a patient come in to me who read my book and brought it into me. And I was like, okay. I was like, okay, you probably don't have to advocate with me as much, but that's good. Let's do it. I've had patients reach out to me and say, I have a long-time relationship with my physician. I didn't feel like I was getting anywhere, and I used this strategy and it worked. So I think there are ways to approach, and I think approaching with love, curiosity, and like understanding where that person's coming from is probably going to be better than like, you suck, didn't you know this thing?
What is sort of your top recommendation for us, for women in midlife right now, to become strong?
Yes. And I'm going to tell you that before I go right there, I want to say, what is our goal? What is the goal of what I'm about to say to you? It is longevity, and it's health, longevity, and power. Power is strength over time. If I want to be strong enough to not fall down in my own kitchen and break my hip, and therefore 50% will not live by themselves again, and a third will die, right? If I want to be strong enough to go take a walk by myself, go to the grocery store, go get my hair done, visit my kids when I want, what does that take? That takes power, a lot of muscle fibers firing at once repeatedly, and that takes lifting heavy. If you have no time, I have 4 or 5 things that are a lifestyle that become not hard when it's how I live, right? But if you're starting out and you only have 1 hour and you're like, this woman is telling me to do too many things. How many things? One thing is to go lift heavy. We must lift weights. We must put down the mamby-pamby pink weights and lift as heavy as our bones will let us. Because in doing that, and I'll define heavy in a minute, in doing that, we will stimulate muscle protein synthesis. We're going to make more muscle. We're going to rejuvenate our muscle stem cells. We're going to build better bone, right? Muscle contraction causes transcription, which means the making of a protein that goes to our brain and makes us more resilient. There's almost nothing that muscle will not contribute to. So if you have 1 hour, you go start lifting weights. And if you've never done it before, now is the time to put off buying the new thing that you want, maybe the shoes with the red soles or the hot bag. I'm as guilty as everybody else, but maybe we postpone that, or postpone our $7.18 a day drink at Starbucks, also guilty, and invest in some training, right? You're learning a new skill, hire a trainer to teach you so you don't get hurt, and then you're going to lift. If you have 2 things to do, then you're going to lift 3 or 4 days a week, and you're going to walk at a low heart rate every day, and twice a week, you're going to sprint. Now, the word sprint scares people, but what it just means is your maximum effort. So let me give you examples in real numbers of those 2 things. When I say lift heavy, it means that in 4 basic compound motions, meaning push with your arms, pull with your arms, bench press, pull-ups, pull with your legs, push with your legs, squats, deadlifts. There are hundreds of varieties of these things. I want you to do 4 reps, 4 sets, not 20 reps of the lightest thing you can possibly do. that has its place for mobility, but if we're trying to build muscle and be strong, we must lift heavy. So let's give you an example from my arms. Biceps curls is not a compound lift, but if I were biceps curling, I could biceps curl 15 pounds until tomorrow morning. But I can only biceps curl 25 pounds 4 times before I'm hauling my whole back into it, right? But in working to exhaustion like this, we're helping to build muscle. You must feed the muscle building process by eating enough protein, which I think is 1 gram per ideal pound a day. And we can talk about how to get that much in. So that's my muscle example. My sprinting example, because that word scares people, your maximum effort example is when I'm doing base training, meaning lower heart rate training, where I'm building metabolic efficiency. My treadmill incline is at 4, and you can do this with anything, walking outside, bike, treadmill, stair climber. It's about your heart rate. But for me, incline of 4 and speed of 4. And I'm just going along for 45 minutes, breaking a little sweat towards the end. When I'm sprinting, I punch it up to 11. I go as fast as my little legs can carry me, and I try not to fly off the end of the treadmill because I'm a short person. I'm only 5'4". That's sprinting to me. I don't look like Richardson, this amazing woman, a sprinter, or Usain Bolt. I look like Vonda Wright trying to go as fast as she can. But in doing that, that is critical for muscle stem cell rejuvenation.